Hello, my name is Olamiji Adeporose. I'm going to be presenting ketamine mediated treatment for major depressive disorder. What is a major depressive disorder? According to the American Psychiatric Association, depressive disorders are characterized by sad, empty, or irritable mood, accompanied by somatic and cognitive changes that significantly affect the individual's ability to function. Major depressive disorder is characterized by episodes of this mood and symptoms for at least 2 weeks, with intermittent remissions. Depressive mood persists throughout the day, nearly every day, with other accompanying symptoms, distinct apathy for all or nearly all day activities, weight loss due to a loss of appetite, insomnia, hypersomnia nearly every day, feeling of worthlessness and excessive guilt, and so on and so forth. Now, who is affected by major depressive disorder? According to the National Institute of Mental Health, approximately 16.2 million United States adults, it's about 6.7% of the population, had at least one major depressive episode in 2016. The prevalence of MDD is higher among females, 8.5%, than males, which is 4.8%. Major depressive disorder is most prevalent among adolescents/young adults, with 10.9% of cases occurring between the age of 18 and 25. Also, 10.3 million adults of the population had at least one major depressive episode with severe impairment. What are the pathophysiological effects of depression on the brain? According to a study conducted by Domain Correlated Chronic Stress, which is associated with MDD and neuroatrophy, or the loss of synaptic connection in key cortical and limbic brain region implicated in depression. These key regions include prefrontal cortex, hippocampus, cingulate cortex, amygdala, and basal ganglia. Domain also demonstrates that neuronal atrophy is associated by a lack of neurotrophic growth factor support, specifically from the protein brain-derived neurotrophic factor. As a result of these two factors, the regions of the brain associated with stress mood management becomes impaired and depressive states ensue. How is MDD currently treated? Treatment for major depressive disorder typically involves psychotherapy in conjunction with pharmacological agents as needed. Cognitive therapy aims to combat cognitive distortion, such as overgeneralization, selective attention to negative of life, and so on, caused by MDD with positive way of thinking. Cognitive behavior therapy falls under this category. Interpersonal therapy encourages patients to focus on the interpersonal relationship that root MDD behavior in an effort to change them. Pharmacotherapy, in particular, aims to improve the means by which the brain chemically controls stress and negative mood, thereby producing an antidepressant effect in the brain. Examples of antidepressants are selective serotonin reuptake inhibitor, selective norepinephrine inhibitor, and the tricyclic antidepressants. How do current pharmacological agents work in the brain? According to Mayo Clinic and Stanford University, SNRI such as Cymbalta and TCA such as norepinephrine increase the level of serotonin and norepinephrine by blocking their reuptake channel, which produces an antidepressant effect. SSRI, such as Prozac, increases the level of serotonin in the brain by blocking its uptake, which produces an antidepressant effect. Proposed policy change: ketamine as a potential new agent for MDD. Ketamine has been under study for almost 20 years and has shown considerable potential as a pharmacological agent for major depressive disorder. According to Forcade and Lapidus, ketamine acts as an antagonist and produces a rapid and potentially long-lasting antidepressant effect, even for treatment-resistant MDD patients. Thus, mental health providers should consider implementing ketamine-mediated psychotherapy regimen for major depressive disorder patients, especially those with treatment resistance. How does ketamine work in the brain? Ketamine acts by stimulating the release of the neurotransmitter known as glutamate in the brain. Glutamate are so critical to neural activities in the central nervous system. In fact, that some scientists have dubbed it to be master switch. Glutamate is associated with learning and memory, and is crucial to synaptic plasticity and neurodevelopment. The antidepressant effect of ketamine occurs in 3 steps. Ketamine binds to NMDA receptor and thereby inactivates them. NMDA, which is expressed on inhibitory interneurons, regulates the release of glutamate from pyramidal cells in regions of the brain such as the PFC. Inactivated NMDA receptor no longer inhibits the production of glutamate in pyramidal cells, leading to an increase in glutamatergic activity. This increase in glutamate activity induces increase in cell signaling and synaptic plasticity connectivity in key regions associated with the limbic system, particularly the PFC. Ketamine and major depressive disorder. 4 fundamental evidence-based ketamine studies. A study conducted by Berman investigated the effect of increased glutamate production as a result of ketamine infusion and antidepressant effects. 9 patients with major depressive disorder underwent a ketamine/placebo trial. The experimental group received ketamine infusion for a total period of 2 days with a week in between. Prior to and after treatment, patients were rated on 4 different depressive spectra: Hamilton Depression Rating Scale, Visual Analog Scale, Beck Depression Inversion, and Brief Psychiatric Rating Scale. Results of the study show that ketamine treatment resulted in a significant decrease on the HDRS and BAS, and significant increase on BPRS, which indicates more positive mood within days of treatment. Borman concluded that the result of this study suggests that low-dose ketamine infusion as compared to placebo is associated with robust decrease in depressive symptoms emerging progressively within 3 days. Serret conducted a placebo ketamine study similar to Berman in order to study the effect of ketamine infusion on depressive mood for MDD patients. 18 patients with treatment-resistant MDD were given either ketamine or placebo infusion for 2 days, a week between. Prior to and after treatment, patients participated in the Hamilton Depression Rating Scale. Subjects who had received ketamine infusion displayed significant improvement in depression. 71% of those who had received ketamine met antidepressive response criteria, and 29 met depression remission criteria. 35% of these subjects maintained response for at least 1 week. Diaz Granados conducted a study on ketamine's effect on suicide ideation in MDD patients after a single infusion of ketamine. 33 subjects were rated on the scale for suicide ideation: Montgomery-Åsberg Depression Rating Scale, Hamilton Depression Rating Scale, and Beck Depression Inventory, prior to and after receiving 1 infusion of ketamine. Results show a significant decrease in SSI within 40 minutes of treatment, and this result persisted for the first 4 hours after infusion. One conducted a study on ketamine safety and tolerability as a treatment for treatment-resistant MDD. 3 trials of ketamine infusion were conducted on 84 subjects over a span of 2 to 4 weeks, with patients cared prior to and after treatment on brief psychiatric rating scale, Montgomery-Åsberg Depression Rating Scale, and clinician-administered dissociated state scale. 67% of patients experience a significant decrease of MADRS score within 24 hours of ketamine infusion. Changing in CADSS score did not differ significantly between ketamine responder and non-responder, but a small and significant increase in psychotic symptoms measured by the BRPS was observed for multiple patients. One concludes that the findings from this study show that low-dose ketamine is safe and well tolerated in patients with the context of a well-controlled medical research setting. Further research, potential adverse effects of ketamine use. Although numerous studies prove that ketamine can quickly and effectively produce antidepressant effects for a long period of time, researchers are less certain about potential side effects of prolonged ketamine use. A systemic review by Serafina on ketamine efficacy recommends further research on ketamine's adverse effects. The systemic review correlated low-dose ketamine use with minimal acute neurocognitive effect in TRD patients 40 minutes after ketamine infusion, citing impairment on the delay recall component of Hopkins verbal learning test. Other studies show that common adverse ketamine effects include dizziness, blurry vision, headache, nausea or vomiting, dry mouth, poor coordination, poor concentration, and restlessness. Studies also show a correlation between ketamine use and dissociation, perceptual disorder, increased blood pressure, transient cognitive deficit, and potential abuse. In essence, researchers heavily recommend that further study on the adverse effects that prolonged glutamate activities can cause before ketamine can fully be implemented into treatment plan. In conclusion, due to prevalence and potential to have a substantial negative effect on quality of life, major depressive disorder must be treated quickly and effectively. However, the demand for effective treatment continues to increase every year, and the emergence of treatment-resistant depression increases these needs. Depression is caused by a lack of synaptic activity in key limbic region of the brain. Current treatment methods produce antidepressant effect but do not address the lack of synaptic activity. Ketamine combats this by promoting glutamate activities, which induces synaptic connectivity stroke activities. Clinical studies have shown that low-dose ketamine use can quickly produce antidepressant effect for a long period of time with minimal adverse effects. Although official research is needed to make conclusions about the adverse effects of long-term ketamine use, some studies have already provided evidence that side effects are minimal. With further research, ketamine may soon help mental health providers provide the highest quality of care to MDD patients.